All right. So I will let you know what we have left today. So in just a moment, I'm going to introduce Jim. I'm going to have a couple closing remarks afterwards. I want to invite some conversation in this communal forum, and then we'll have treats, hopefully showing up in about 30 to 45 minutes, and then we can have more conversation right out there. So, and since Jim has a newer position, I'm actually going to read your bio. I know. I've worked with Jim for about 15 years. So Jim Vollendroff is the director of the Behavioral Health Institute here at the University of Washington. He's worked in the behavioral health field for over 35 years. He spent the first half of his career in direct services before transitioning to the King County Department of Community and Human Services, where he recently wrapped up his 16-year career in December, just the end of last year. And he was the director of the King County Behavioral Health and Recovery Division. And he was hired this year at the University of Washington to lead the Behavioral Health Institute, which is underneath the University of Washington Medicine Department of Psychiatry and Behavioral Sciences. And in this role, he will work to bring researchers and clinicians together to innovate and improve the delivery of mental health and addiction services. So I'm very excited to have Jim here today and generally here at the university. So welcome.
Great, thank you. Great, thank you. And it is a pleasure to be here with everybody today. I just came off teaching my first class at the University of Washington in co-occurring disorders. And it was an all-day Saturday class that happened to be from 9 to 3:50. And so I learned over the course of the quarter that this is a really hard time of day to keep everybody engaged. But fortunately for you, I mastered that over the course of the quarter. So I think that we will actually have a very engaging conversation for the last half hour here. So it is a pleasure to be here. I have been in the field for a very long time, and one of the things that I have changed over the course of my career is I talk about my own personal recovery, something that I kept locked inside for many years. In the first 30 years of my career, frankly, I never talked about my own recovery journey, and I know from experience that there are many people in this room who have incredible recovery stories to tell, and what I've learned too is that people who experience behavioral health conditions have immense capacity to get well, and that's what excites me about this work, and it excites me about working here in King County. I've rarely seen a community who really understands the full need of this continuum of care to actually engage with individuals and to help people get healthy all the way from harm reduction to treatment on the deeper end of the system. So I'm thrilled to be here. So my task is to begin to have a conversation with you, and hopefully the mics have not left the room. I'm hoping that our mic assistants, although I don't see them, there they are ready to assist me here. But we're going to talk about what we've learned today. So I'm going to review some of the things that we've covered, and then I'm going to share some questions to help start the conversation. One thing I did want to do before we do that is give a shameless plug for the Washington Recovery Alliance and a day that they have on Sunday, August 25th. They're going to have a recovery day at the Seattle Mariners game against the Toronto Blue Jays. And I think so far there are nearly 900 people who've signed up to attend that. And so it's a way for us to show up in large numbers and to recognize that people in recovery are amongst all of us. And so the Washington Recovery Alliance has little flyers just like this. Please find one of those or look on their website. Lauren's got a bunch. She's waving over here. So I think there's tremendous opportunities for us to show up as a community to demonstrate how we support people in recovery. So just looking back at the day today, we've talked from and heard from people with lived experience, which I think is incredibly important. And I'm going to talk a little bit about peers in a little while. We talked about the scope of the impact of methamphetamine use in Washington State. We spent some time talking about the basic science and pharmacological interventions of methamphetamine use. We talked about cognitive, behavioral, and social interventions. And then after lunch, we talked about addressing mental health needs of those with behavioral health and methamphetamine use. We talked about support services. And finally, we ended with a great panel on harm reduction. So thinking about those things, I've got got some questions that I'd like to pose. And before I do that, I'd like to just talk about a couple of things that I thought about throughout the day. And I mentioned one of them, and many of you mentioned them throughout the day, but one of them was that there are many paths to recovery. And again, I think that that's a wonderful thing that this community recognizes, that what recovery looks like for me or what recovery looks like for anybody else in this room may look different from the needs of somebody else. And so recognizing that helps us have a full, rich continuum of services for people. Having treatment on demand is critical, and that was mentioned by the panel and throughout the day. And there are some things that make sense in a continuum of care if at the end of the day you have treatment on demand. They may not, in fact, make sense if you don't have treatment on demand. So at the end of the day, for me, until we have the ability for anybody who has a behavioral health condition to walk in and get services that very day, I think we've got to continue to work towards that. I also wanted to, somebody mentioned the siting. Working at King County, I think that was one of the more challenging things that we had, was siting facilities. Nobody wants us in their backyard. There's an issue right now with the sobering center here in Seattle that nobody wants a sobering center in their backyard, and all of a sudden we're without a sobering center as of today for a temporary period of time. So I think that there's a lot to be said about that. I also wanted to mention the abstinence-only issue that came up. I'm proud to say in this state we have very progressive people in Olympia, and there have been movements over a period of time to remove the term abstinence only from the language, that recovery was about abstinence. And over the years, that language has been removed. I think it was just this last session that was actually removed? So this last session, the goal being abstinence was removed with the recognition that that may in fact not be the goal for everybody. So we continue to chip away at these things as a community to make things even better. So thinking about today, what I'm going to ask of you is to think about the key highlights or takeaway from today's conversation. I know if you're like me, either during the breaks or at lunch, I had incredible conversations with people about what they've learned, what they've heard, and what they're taking away from this already. I'd like you to also be thinking about how has what you've heard today challenged what you thought about addiction, methamphetamine in particular, and treatment, and what might you do differently. So I'm going to stop there and give the audience an opportunity to respond to those two questions. What are some of the key highlights that you've taken away from today's conversation that you'd like to share with your colleagues? And we're recording this so we can do something with this. The purpose of today is to listen to you and then to create an avenue for future conversations around this. So what are key highlights or takeaways from today's conversation that anybody would like to share with us? Okay, we got a comment right here. We'll start over here.
Hi, Efren Davis.
Good.
Efren Davis, Pierce County Probation. One of the things I took away today was, when we talk about recovery and we talk about support groups, there's a belief in the corrections field that support groups means 12-step. And one of the things I heard today is that's not necessarily true, because support groups can mean a whole lot of things. Even our department's changing how we feel about support groups, because it's about that person connecting with the community and being a better person. And if that's the case, then whatever support they get to help them be a better person, that's what true support means.
Yeah, that's incredible, and I think that well said. The Recovery Cafe was mentioned today, connection was mentioned today, and you can get that kind of support through a lot of different ways, and whether it's faith communities or other networks, there are many ways, and again, it points back to that there are multiple paths to recovery. So thank you for that comment. Brad?
So originally when I heard about this convening, I was a little bit dismayed, in all honesty, because I think we do so much of treating silos, right? I mean, there's been so much opiate work that's gone on that has not allowed flexibility into other arenas. And now, just to focus on methamphetamine. But for me, it's really surpassed many of my expectations, because what we've really talked about today is whole person care, no matter what somebody walks in for people with substance use disorder, and people who have behavioral health challenges. I think one of the challenges that we need to be able to tackle in this field is the flexibility for our care providers in different settings to have flexibility in care. There's so much siloed as far as like housing funds this particular activity, treatment funds this particular activity, support services may be funded for this particular activity. But how do we bring it all together under one roof for a single person? Because that's true integration, right? Representative Cody was the author of 6312 and moving towards integration. And now how do we actualize it and implement it so that people can really receive the care that they need in one place?
Yeah, that's incredible. I think that the whole topic of integration is an incredibly important topic that we are on the cusp of reaping the benefits of. And as we started with bringing mental health and substance use disorder, where in fact they used to be treated separately, and now we've got physical health care being integrated. And once we're finally there in a true fashion, I think we'll begin to, again, reap the benefits of that. So really good comments. I'm going to shift us just a little. Well, actually, before I do that, any other questions or comments? I'm going to shift us just a little bit, and keeping in mind that we have 3 elected officials in the room today. And so and pardon me if I missed anybody, the 3 that I can see from where I'm standing anyway. So thinking about the important policy or research responses needed to address this issue, and I challenge us to think beyond methamphetamine. I think that we can talk about it from a system standpoint, including methamphetamine, but a couple of things that I wrote down that I'd like to just put out there for you to consider. So what are some of the clinical services? And we heard today cognitive behavioral therapy. We heard about contingency management. We heard about a number of different strategies. But what other things have we not talked about that people might want to put out there? And then what are the challenges? I think Brad just brought up some of the challenges. What are the challenges of delivering clinical services in the current environment that we have, the funding environment, the licensing environment that we have, et cetera? Training and workforce development. I think we can't have a conversation today without talking about those issues and getting the ears of our legislators about what are some of the challenges related to training and workforce development. And one of the earlier panels talked about how hard this work is, especially when you're in a position where you're not necessarily reaping the benefits of seeing people get well on a daily basis. That's incredibly challenging environment to work in. I think talking about funding and reimbursement, again, these are things that were brought up throughout the day. I know our legislatures worked on that issue continuously over multiple years, but that's another area where I think that we should be talking about how do we make sure that we are adequately reimbursing providers for the work that they're doing so that they can pay their employees livable wages, so that we don't have the turnover that we have in our agencies continuously. We didn't really talk about youth much today. We talked a little bit about youth, but I challenge us to think about, okay, well, what about young people? How do we, in fact, reach people earlier? I love the idea of reaching people at an earlier stage before, in fact, they're needing some of our services. So how can we keep people, and from a population health-based perspective, how do we keep people who are healthy so that they don't need our services? So what do we do for youth? We did talk a little bit about prevention, but think about prevention. What are some of the things we needed to be doing more on the preventative side of things? I challenge you to think about technology. I think technology was mentioned, and there are incredible things if you're not tuned into what's happening around technology, and whether that's technology related to telemedicine or telepsychiatry or new apps that are being developed. But I tell you, 5 years from now, we're going to be looking back and going, wow, there are incredible things that we're now using as part of our toolkit as clinicians. Thinking about urgent care opportunities and how can we provide opportunities that are outside of the criminal justice system, outside of the hospital emergency departments to help people who are in crisis. Peers were talked about, but I don't think peers were talked about nearly enough today, frankly. I think that peers may, in fact, be one of the answers that we're looking for. I think that peers have the incredible opportunity to help help advance our services. I think about peer bridgers. Peer bridgers are now being used from Western State Hospital back to the community. Are there opportunities for us to connect peers more with people who are active in their addiction, people who've been in that situation and are now in a different place in their recovery? And I'm not necessarily talking about peers who are not using even, just people who have lived, shared experience who want to help one another. And then finally, there's some work happening around community information exchange. How can we talk better with each other? How can we share information about a client within the bounds of HIPAA and under the guise of federal confidentiality to advance care? So in fact, most of the people that we work with are multi-system involved. And so how can we make sure that we're not, in fact, tripping over each other or missing something if we have a better opportunity to share information? And the Accountable Community of Health, Healthier Here in this community, is working on a community information exchange so that we can, in fact, do that. So I'll stop and ask for your reaction to any one of those or anything else we may have missed in terms of clinical policy or research opportunities or responses. And we'll start right here.
So I think peer support is huge, and really looking to peers as the leaders and experts in informing this work and informing the research especially. And I think paying peers and people who are identify as drug users currently and past, I think working with those people and really paying them and supporting them in informing this work is something that we should put at the forefront.
Great. I totally agree. I think that's incredibly important.
This is because I'm sitting at the University of Washington with a bunch of researchers. One of the things that we are required by law to do in the Medicaid program is pay for evidence-based programming. And just looking at the slide shown today, the systematic reviews that find 1,000 articles and end up looking at 20 because the quality is such that that's all there is, we need more information about how long do people really need? Do they need residential treatment? And if they do, how long should it be? And for what subgroups of people? We want to be able to pay for things that help people get better, but honestly, we don't know what that is. We know what tradition says, and we know in some folks that works, but in a lot of folks it doesn't. So I am asking the researchers in the room to help us better define what works best for what kind of person, so that when we, set up a benefit package and we negotiate with the plans and we try to get the right services to folks, that we have some information on which to base that and not just passion. We all have passion. That's not a problem. But now we need to know what is it that this particular subset of folks do best with, recognizing that everyone's different. But that is a plea from your friendly state Medicaid agency.
Thank you. I think that's incredibly important. And I just had a conversation with an individual the other day about changing payment methodologies and how that will advance care, in fact. And you mentioned that earlier today. Because for those of you that provide outpatient substance use disorder services, I think many of you know that the bread and butter of that is group counseling. And so you got one clinician with 16 individuals, and that begins to drive care. And then all of a sudden, everybody's in this 16-week program. And in fact, there's better ways for us to deliver care and probably get better outcomes. So that's a great comment. Let's see, back here, right over here.
Hi, so this is Erica. I work for Jail Health Services, and we didn't talk about anybody leaving jail and coming back home or coming back to the community. So I think that's something that should be talked about more. But since we talked about connections, I think we should talk about the importance of belonging. Connecting people is one thing, but people need to feel like they belong in their communities. And what structural barriers do we put up or do we ignore so people can't feel like they belong? It's a little bit different than connecting people to support groups. It's looking at who's in the room right now and do we represent the people that we're serving the most, especially people coming from jails and prisons.
Great. Thank you, and incredibly important. Thank you for that comment. Back here. Whoops, sorry, we got somebody on this side, and then we'll get over there. Sorry about that.
Thank you. To Sharissa's point about standards, I think we have an opportunity with Senate Bill 5380 to develop standards for opioid treatment programs, and I hope that we can have some space for this topic in that standard building process.
Thank you.
Thank you. My name is Johnny Otar. I work with homeless youth, and I'm kind of wondering how we can make long game evidence-based practice. I heard about this talked about today. I work with Lead Reach and lots of other people, and obviously people come and go, and they get housed and not housed, and they go home and they come back, and so many different things happen. They go to jail, they go to juvenile, they go to all these places, and very few of us are able to stay with them. And I have the opportunity to do that, but that long game is a big thing, and it's very beneficial, especially for young people, because I have many, many young people that were deep in addiction and homelessness who are 26, 27, 28, 29, 30, who are now doing really very well and living very healthy lives in recovery of whatever that recovery is. They're not using meth. So that long game is something that really pays off. And we do have programs, and we have talked about it a little bit, but it's something that's beneficial. And then, well, more than beneficial. And on a side note, I think Christina said we're in this epidemic now, and in 5 years we'll be in another one, and I'm ready for this one to go. I don't know what the next one's going to be, but this one's tough. Thank you.
Yeah. Thank you. And Johnny, you bring up such incredible points. I think that one of the challenges that I've seen in the system over the years is that we have these different modalities of care, and once I'm done with my modality, I'm done with that client. I may give them an appointment, and I may say, here, Caleb, here's your appointment. Good luck to you, versus really investing in inpatient treatment if that's what an individual needs, and then wrapping services around them and continuing to follow them. I think that's an incredibly important point.
And that was a perfect segue into what I was going to say, and that is care coordination, because we've looked at several components, and we have touched on it with support services and with peers, but how do we knit all those pieces together into a true system? And I would suggest that happens with care coordination, patient navigators, nurse care managers, behavioral health aides, and those can make the difference in helping to get those people where they need to go and provide that connection along the way, so that it does become a system instead of all these different dots that are not connected.
Yeah, incredible. Thank you, Shelley. I think that, I've talked about this a lot, and we wait oftentimes to admit people to treatment. That if you had cancer, it would be the equivalent of admitting people at stage 4 cancer. And that's a very simplified way to say it. But we admit people when they're really sick. And imagine if we admitted people when they first showed signs and symptoms, and then, like you do with other acute illnesses, you followed them and you continued to check in with them. We might have better outcomes. We might see some better things. So comment over here, a question? Oh, sorry, right here. Go ahead. Right here.
Me? Okay.
Yeah.
Alison, I'm from Clallam County again. So I really appreciate everything that's been talked about today. My request would be to remember the state outside of King County. So when you look at Caleb's initial slides, some of the reddest parts of the state are where we live. And it's a different world out there. We don't have a quarter of the services that you guys are talking about. And so figuring out how we can disseminate these best practices in the rural areas in a way that they will be accepted, because just like Caleb also mentioned, a lot of us are losing the services we got. So the syringe exchanges are closing. I'm able to keep mine open for 3 hours a week, and even that is a high political cost. And so seeing how we can support maintaining these services would be really helpful for us.
Yeah, and thank you so much for reminding us of the nature of our diverse state. And when we were looking at the slides earlier, Johnny and I were commenting on that northeast corner of the state and Clallam County, all these areas. So thank you for pointing that out. And I think that that's a challenge for our legislators in the room to also continue to think about. I'm sorry, I'm going to have to rely on my mic, folks, because I'm losing track of where questions are at.
Yeah. So, Carl Moore, Tacoma, Pierce County. Known Mr. Vollendroff for a while. So, one of the things
I've known most everybody in this room for a while.
One of the things I kind of get, dismayed about is, we do these symposiums, we do all this research, we do all these things, but we forget about the humanistic value of the work that we do. So all these people that are here, we don't take that information back and filter it down to build relationships with the individuals that we serve. So no matter what you have to give someone, if they're not trusting of you, if they don't feel confident in you, they're not going to accept whatever it is that you have to give them.
Thank you, Carl. Okay, we're going to have time for 2 or 3 more questions. So,
I'm Christopher Manis. I'm an AmeriCorps Vista serving with Lifeline Connections, and I'm kind of curious about that relationship building aspect as well, because we utilize peer counselors through our outpatient programs. But one of the tensions that we have in trying to break down those barriers, that stigma, is what amount of disclosure is appropriate in that outpatient setting, because those stories are important to share with people. But at the same time, we only want to deliver that when it's beneficial to the client. So I'm just kind of curious if the room has any insight as to what levels they've seen as been effective, or along those lines. Yeah.
I can say basically the only thing that I ever share, if it's not going to benefit the client, then why am I sharing it? So it's always been that simple for me. When I first started, I wanted to be, want them to know who I was and where I was from and all this. If it's not going to benefit them and take them into a different place, a better quality of life, then why am I sharing it? It's not for them, it's for me. And that's not cool.
you bring up, that's a great question, and I had a conversation with some colleagues about that during one of the breaks. And I don't know that we're going to be able to get into that completely, but there's a place and time for people to talk about their own lived experience, and there's a place for us to question why we're doing that. And so I think, Carl, your comments are right on.
Hi, my name is Darcy Reitenauer. I'm the chairman of the North Sound Recovery Coalition up north. Was it Snohomish, Skagit, Whatcom Island, and San Juan. I go to a lot of meetings and talking about certain populations. And the first question I always ask at the table I'm sitting is like, where's the person who's lived experience? They should be at our table. One other thing, with Lauren, I so appreciate Recovery Advocacy Day down in Olympia. I got a bus of 56 people, and half those people were in recovery, and they were on a high for 2 months. I'm not even kidding you. And the other thing, too, is I'm a trainer for a recovery coach, CCAR recovery coach. I don't know if you guys have heard that or not, yeah. I've trained over, the last 5 years, 250-some people up north, Alaska, Utah. And my funding just got cut, and I'm searching. But I don't just do it for recovery, as a recovery coach. I see it as this is my community conversation about recovery. We do not have enough conversation about what recovery is. They don't know. I went to school to be a psych nurse with a focus on addiction. I ended up going into nutrition instead. I went into CDP. I didn't want to be a counselor. I want to concentrate on recovery, and I have for the last 5 years. And I'm so happy to see recovery, because 5 years ago that wasn't even a word. It wasn't even something we even talked about. So when I teach, when I train people, it's a conversation, because there's no other class that has recovery's parents, teachers, counselors, not a judge, a lawyer, nurses, all in one room, and they come out in 4 days and they're like, wow, I'm blown away. Yeah. Because they're having this conversation against each other. So I'm happy to be here. Thank you guys so much. And
we're glad that you're here.
I'm honored. Thank
we're
you.
glad that you're here too. And the Recovery Day in Olympia has grown. I think there were over 400 people there last year, and it just keeps getting bigger every year. We have time for one final question over here.
Yeah, just on the topic of inpatient treatment in our state as well. I think 80% of people who qualify for a substance use disorder in the nation, SAMHSA came out with a study in 2015, did not access traditional treatment. So we have to have this spectrum of services, and it has to start with harm reduction. But when people are ready for inpatient treatment and they have co-occurring diagnoses, there are very few options in our state, and we have had to do incredible advocacy, even for someone who has been stabilized on medication for a certain amount of time because of a particular delusion, and how will they handle that in inpatient. So there's, and culturally appropriate and adaptive and treatment in other languages than English is also lacking in our state.
Thank you. That's incredibly important. And I will say, thanks to our friends in Olympia, we did get some funding this last session to actually do some training and some curriculum development specifically for substance use disorder residential treatment, including co-occurring, to look at some of those very issues that you brought up. So through the Behavioral Health Institute and partnering with Caleb and his group, we will be doing some of that exact work. So I'm going to wrap up here with just saying that there have been a lot of ideas sparked today, and Caleb is going to wrap us up with just the what's next. Where do we go from here? And thank you all for being here today. It's been incredibly fun and energizing day to be with you.
All right. I do want to talk about what now, because to everybody's point, this is all kind of interesting, but what are we going to do about it? And I think part of this is really letting you know some of the resources we have out there, both in terms of information, but also about continuing the conversation. And also, please feel free to reach out to me to think about, do we want to have additional dialogues like this? Do we want to have it by discipline, by region? Do we just want to do something like this? Again, let me know. I do think I've already gotten the little registrations. I encourage you, if you didn't already this morning, and to get all of my alerts, please do sign up for the email list. It's going to be the best way to keep the conversation going, so please do that. It's right there. And we can make sure it's posted out here. I want to talk a little bit about some of the things we've talked about. I want to talk about prevention efforts, make sure people know about some of the resources that are out there. One of the main resources that the State Division of Behavioral Health and Recovery supports is the athenaforum.org webpage. We have a prevention research subcommittee meeting, and so we got to come up with some better monikers. But I'll tell you that ADI hosts quarterly meetings both on prevention, I'll talk about it as well around treatment, bringing together people who are practitioners who do work in this area. So prevention practitioners, except I spelled it wrong because that's what I do sometimes, and researchers, they coming together to share ideas and establish partnerships. And so that's really important, to get people coming together and talking to make sure we're not just doing the same old thing, hearing about what emergent needs and really making sure we're stepping up and addressing those. Treatment training resources, I'm going to mention a few of those. I want to let people know about the Northwest Addiction Technology Transfer Center, which is hosted at the Alcohol and Drug Abuse Institute. And they've done a recent training. There'll be some other trainings coming up soon around folks with stimulant use disorder that are more clinically oriented. So there's clinical trainings that are available, and the Northwest Addiction Technology Transfer Center can be a go-to place to also reach out and get trainers to come work with you all. There's a lot of things. I'm just going to touch on a few of them. There's a lot today I would have loved to have covered. We couldn't cover it all. But I want to mention also in terms of psychiatric services and supports for providers you're working with who are need help in terms of clinical services. There is didactic, there's educational, and also clinical consultation services available through the University of Washington on a whole range of topics, one of them around psychiatry and behavioral health and addictions. Also, to make sure people know, I apologize, the logo is small, but you can just remember the Washington Recovery Helpline is a great place to call. They have tons of staff and volunteers who can connect people to treatment, with a capital T, but also to support services and recovery supports. And that's really important that people know that that is a go-to resource and that they've got multiple ways to communicate. And I think the texting they've been bringing online will also be really important to reach out and engage young adults as well. In terms of future technical assistance, so I just want to mention that we're very clear today is not a clinical training, as you saw, but we really can leverage some of the resources of infrastructure we have with some state and federal funding. Particularly, we're doing a lot of work. My group is doing training and technical assistance and clinical consultation for something like 28, a lot of opioid treatment networks across a lot of Washington state. And we're actually looking at doing some supplemental trainings in the fall for clinicians, particularly around the concomitant use of methamphetamine. I think the other thing is, while this is, we call it a methamphetamine symposium, I think we've heard over and over and over again, what we're talking about is totally relevant for other substances and other behavioral health conditions. Methamphetamine happens to be the topic that maybe got you to come today, but I think you get that this is about really services on demand for people. This idea of parent-child assistance program is awesome and certainly worthy, but why don't we all get that? mean, that's something we could try to make manifest, not 3 months of care navigation or 6 months of care navigation, but 3 years sounds pretty good. 3 years sounds like that might be something, and particularly what we talked about with methamphetamine, with cognitive impairment, and the time it might take for that dopamine system to come back online. We also have a webpage that's coming out soon, which if you're registered, we will send you the link to. I think I'm selling something, but it's all free. About effective treatment interventions, and really both for staff and client resources and the general public. The idea in some ways, if people are familiar with SAMHSA's treatment resources, they're quite interesting. They're kind of over the top and intensive. As an example, they have a 64-page document that explains opioid treatment medications. We created a 2-page version. So we like to make it a little simpler for everybody, maybe a little more useful, and so we're going to be getting that out. Hey, look, I put up there, sign up for the listserv. So Jim already mentioned this. We'll be continuing to work and partner and grow what this Behavioral Health Institute is and what the University of Washington can continue to offer. We are working and need to do a better job coordinating our own clinical and research services within the UW because we're really big, and we need to do a better job at that to get our own stuff together. And then we also need to really make it clear to the general public how you access and reach out to us. How do you learn about the latest research? How do you get clinical supports for your clinicians who are in beautiful Port Angeles, or maybe even Squint, or maybe even Neah Bay, and really remote and need clinical backup? That's just really essential. If we're going to ask people to do new types of services they're not comfortable doing, we can't just tell them, oh, it's evidence-based, why aren't you doing it? Oh, you're doing malpractice. I tried that. It doesn't work. You need to actually give people the tools they need to implement these services, and of course the funding as well. Harm reduction resources, we are blessed in a lot of different ways. People's Harm Reduction Alliance is obviously really a forerunner here. I want to mention that, so take a look at their webpage. They have a lot of great information. If you are looking for something that's not quite there might be some things on the Harm Reduction Coalition's webpage that might also give you some good actionable materials or handouts for folks. We have a webpage, stopoverdose.org, that's largely targeted around opioids, but also don't forget about that Good Samaritan law that applies to all controlled substances, and it also applies to minor in possession, and has also led to a lot of conversations in a lot of communities, and more need to happen with law enforcement and prosecutors about how are you going to treat these people who are in medical crisis? Are you really going to criminalize this? Is that really what you need to do? And of course, there's actually law that can help back that up. I'll mention also, most people are probably familiar, we've been very fortunate to have backing from DBHR to fund the Center for Opioid Safety Education for many years, I think 4 or 5 years. And we're very happy to be expanding that on Monday to something that maybe it isn't quite as pithy, but it's the Center for Drug Safety and Services Education, and trying to really expand and think about what else do people need. We're not just focused on syringe exchange, we're not just focused on opioids. What about people who are smoking substances? What about people who aren't coming to these service centers? How do we get harm reduction embedded into every housing program across Washington State? One thing I'll mention that we've seen in several places is when they start offering basic, small-scale syringe exchange within their agency. Bailey Bichet House mentioned this to us, and I'll use them as an example. They gave an estimate that they thought maybe a small proportion, maybe 10% of their clients injected drugs. They started offering syringe exchange services, and guess what? It was closer to 30%. So if you offer services, you have a new way of engaging with people, and that's a great first step. It's showing good faith with people, and I think that's incredibly important to do. And we're also very fortunate that our State Department of Health is also expanding some of their capacity and services to help both in syringe exchange and more broadly around harm reduction services. So I encourage you also to think about my favorite topic. It's actually not, but I like research, and encourage you to really think about immediate opportunities to evaluate novel projects. If you're about to launch a novel project, let us know. We have a ton of students who really want to be testing this type of work in the real world. I'm a big fan of real world pilot testing and really trying to document that well. It's really important. Or if you just have an intervention and you need a community partner to test it out, if you're a researcher, really coming together. And so we have this group, this treatment research subcommittee that's meeting quarterly. I would invite every single person here to participate in that. Yes, really, even you, everyone. And I think we did have somebody from Coordinated Care on the last call, and that was really important as we were talking about care navigation services as an example. Well, what is that? How do you fund it? How do you staff it? How do you train to it? That's really important. It's important on the provider side in terms of actually how do you deliver care, how do you pay for that care, and then how do you actually research it and document it so Dr. Fatinos and our state will reimburse it. And this is really, again, to bring people together to find out what are all these amazing things that people are doing or want to be doing, and let's just do it, because we can be testing this in real time. I encourage you to follow us on our amazing social media platforms. So these are out there for you as well. And then again, I just want to remind you of our goals. I hope we met a couple of these goals for each of you in terms of having a better understanding of what's going on, maybe got an answer to a question today, generate some new questions, even better maybe, meet fabulous people, keep meeting them because I know the desserts are here, and have an action step that you can do. And lastly, just my thank yous. I really want to thank the Division of Behavioral Health and Recovery for supporting our work generally, the symposium in particular, and our staff, Nancy Sutherland, who is probably still out at the desk, who has really worked amazingly hard in terms of logistics. Nicole Branch is also out there. Meg has been a logistician extraordinaire, helping us make everything actually work. That was one PowerPoint, and it worked seamlessly. Has anybody ever seen technology work that seamlessly? You have not. And it's these folks right here. And then also the truly fabulous Susan Kingston in terms of helping us put the panel and moderators together. Thank you all very much. Let's go eat some sugar and fat.